Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and welcome everyone to the next session of NAMS Navigate Medico CME program. And this time in continuation with the last lectures on respiratory medicine by Professor Rajendra Prasad sir. So we are having another interesting topic with very limited therapeutic modalities known. Like at one point of time, people they say that now we have reached the last resort of therapeutics. So this time we are sorry for the technical glitch. So this time we are privileged to listen to Professor Rajendra Prasad sir on update on chronic obstructive pulmonary diseases, which is very, very important. So with this, I would like to request Professor Umesh Kapil sir. Sir is Secretary of National Academy of Medical Sciences. So I would like to request sir for the welcome address.
Namaskar and good afternoon to all the participants and respected faculty, Dr. Rajendra Prasad sir. It's a proud privilege to welcome all of you on behalf of National Academy of Medical Sciences. As you all know, that Navigate program is basically a national virtual graduate education CME program. If you look at in a large country, we do not have the faculty who are eminent, who have contributed nationally and internationally in a particular field. So National Academy of Medical Sciences started this program in 2022 with the aim of having all the eminent people to give sessions, CME sessions on specific topics, particularly in area which they have contributed over a period of last 30-40 years. The main aim is, or the target group is postgraduates, young faculty members, and senior faculty members who are interested in this field. Now, we also intend to have, with the availability of internet at the CSC, PSC, district hospital, we would like that all these doctors who are present in these institutions should also attend this course and update their knowledge. Because what has been seen that once they join the services, the CME program is not conducted for them, and their knowledge remains almost same unless until some have an initiative to take up the studies and go through the recent journals. Now, what we do is that all these lectures are put on the NAMS virtual library, on NAMS website, and all the PowerPoint, all the video recording is on the our website, and this is also telecasted on YouTube, so a person can have a look. Maybe if he has missed the opportunity, he can look subsequently. Now, I would like to say 2-3 words about this today's topic. There's COPD, which is very commonly called. It is one of the most important cause of disability, poor quality of life, loss of productivity. If you look at the prevalence of smoking of BD or cigarette or use of fuel which is being done in the rural area, still the cow dung or the woods are being used, which is a major cause of air pollution, which leads to COPD. In fact, some of the occupations, if you look at, they also cause COPD, particularly silicosis. If you look at the people working in the marble industry, the stone crushers, and so on and so forth, they do have a poor quality of life and they become disabled very fast, and which is an important cause of loss of productivity in our country. So we don't have the facilities also at the PSC level, CSC level. One of the common method of diagnosis is spirometer, and these instruments are not available also at the peripheral level, which is leading to the poor diagnosis. And also the precautions which are being recommended by the government of India are rather not user friendly, and it becomes difficult for them to use it and work efficiently. Although the government of India provide these appliances or what you call contraption to these workers, but they don't find it user friendly and they just don't use it. And this is what I think. So the update on COPD by Professor Raindra Prasad, who is one of the most eminent chest physician, will talk about it. And please ask as many as questions, whatever queries you have, you can just ask it, put it in the chat box. End of the session, we'll put up the question answer session, and I'm sure you would like to enjoy it. Over to you, Jaswant. Thank you very much.
Thank you, sir. Now, I would like to request Mr. Raviji for a message from President, National Academy of Medical Sciences, Dr. Digambar Behra, sir. Yeah, please.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIMS New Delhi and 16 other AIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various aims are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. So now it's my turn and it's my honor to introduce today's speaker. We are again privileged to hear to you, sir. So Professor Rajendra Prasad is currently working as Director, Medical Education and Professor of Respiratory Medicine at AIRA's Lucknow Medical College and Hospital in Lucknow. Sir is also Emeritus Professor at National Academy of Medical Sciences. He has held various positions, including Director at VP Chest Institute, University of Delhi, and Sir has also been specially recognized by international as an international governor of American College of Chest Physicians, USA. Sir has been awarded many awards, including prestigious awards like Dr. B.C. Roy National Award for Developing Pulmonary Medicine in India and Dr. R.C. Jain Lifetime Achievement Award by Tuberculosis Association of India. So the list is long. So instead of citing all names, I would like to we would like to listen to Sir. So I would like to save the time for all of you, and also to mention that Sir has published numerous articles, book chapters, and Sir has supervised thesis. Sir has authored 12 books, including 4 books on tuberculosis. So, and Sir is currently among 2% scientists in previous year ranking as well as career long rankings with citation over 10,000 times, which H index of 48. So with this brief introduction, I would like to hand over the dice to our eminent speaker for today's session, Professor Rajendra Prasad, sir. Sir, over to you. Over to you, sir.
Thank you, Jovinder. Thank you very much. Thank you, Dr. Kapil, for nice words. And at the outset, I'm very thankful to the National Academy for allowing me to present this lecture on COPD. And let me share my slides. क्यों भी ऊपर चली जा रहा? So, as you have heard, Dr. Jogendra, my topic is chronic obstructive pulmonary disease, an update. Although this subject is a very vast, and there has been books written on chronic obstructive pulmonary disease.
Sir, can you please make it full screen, sir? The slides are.
Yeah. Okay. It's okay now?
Yeah, sir. It's very well visible. Thank you, sir.
So my, as I was telling, that subject is a very big, but I'll touch some salient issues about the CCOPD. As Dr. Umesh Kapil has rightly said, that is one of the common condition globally as well in India, which is creating problem. So I usually start my lecture with this proverb. I was in Japan way back in 1889. I learned there that better than 1,000 days of diligent study is one day with great teacher. And I'm not saying that I'm a great teacher, but I said these words for my mentors. First 6 or 7 photos are from my own mentors from KGMC, and then the rest are from Delhi. One of them is Professor P.N. Tandon and Ganguly Saab and Hari Gautam. They all mentored me in one and another way. So they have been a great teachers. And these are my institute where I have worked. My initial work has been, my main work has been in KGMC, then Safai as a director, then Patel Chess as a director, and currently I'm working in Eras Lucknow Medical College. Before I go to my own lecture, I would like to share 2-3 slides that many of the postgraduates and young faculty might have joined. For them, it is interest to them. You have heard about National Academy. You have heard the message of Dr. Behra, who's currently president, and you have heard that this was established long back. And how you can be associated with National Academy? Well, senior person can become fellow. You can become member. Membership is very easy now, I must say. If you have 5 years of experience after your post-graduation, if you have minimum of 3 publications, you can apply for membership. New thing has started as associate fellow person who are DM, MCH, and if they are less than 45, they can apply for associate fellow. And member after DNB is a known fact, what we call is MNMS. And the new thing has been introduced in National Academy as associate member. Even you did your MD, MS, MDS, yeah, you are a senior resident level, and you can become associate member. Application is also very easy, and you can become, a very senior persons can become emeritus professor. As I was talking about the associate member, you need not to go for the fellow for the approval, but for the recommendation. Even your head of institution, head of department, head of unit, or any NMS fellow can sign your application. So things have been made very easy, and I would request all the PGs who are at least who has passed recently and has presented one of the paper in your national conferences, they can apply for associate membership. Now let me go to the COPD, little historical background. Obstructive airway disease and emphysema is a very old entity, and first time it was defined by SIBA Symposium in 1958. And then word chronic bronchitis is still used loosely, and chronic bronchitis clearly has been defined as excessive mucus secretion for most days out of 3 months in each of the 2 or more successive years, without any specific cause for cough and expectoration, like you see asthma, bronchitis. So that was the chronic bronchitis. Then another word is emphysema is associated. This is abnormal enlargement of air spaces distal to the terminal bronchioles. accompanied by destruction of their walls without obvious fibrosis. And when first time COPD was defined in way back in 2005, definition was very clear. Still, it is very, very clear. I will say with you, there's chronic obstructive pulmonary disease is a disease state characterized by airflow limitation that is not fully reversible. Mind it, that is not fully reversible. The airflow limitation is usually both progressive and associated with abnormal inflammatory response of the lungs to the noxious particles or gases. That was the original when COPD was defined by Gold guideline in 2005. The definition was it is telling everything about the disease. Then subsequently definitions has little change, but still essence is maintained. In 2022, chronic obstructive pulmonary disease is a common preventable, another word has been added, preventable and treatable disease that is characterized by persistent respiratory symptoms, airflow limitation that is due to airway/alveolar abnormalities, usually caused by significant exposure to noxious particles or gases and influenced by host factor, including abnormal lung development. Little more defined way, significant comorbidities has an impact on mobility. So little more clear, some more words have been added. And currently in 2025, rather more simplification of is a chronic obstructive pulmonary disease is a heterogeneous, the new word is a heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, expectoration, exacerbations due to abnormalities of the airways, bronchitis and bronchiolitis, and or alveoli. That is emphysema. That causes persistent, again, that word is very important, persistent, often progressive airflow obstruction. Often, the word 2 is very important, persistent. Once there is a COPD, it will remain as COPD, and progressive. Usually it is a progressive. So that is the current definition of it. Now, if you see the epidemiology of it's underestimated. Still, I say, if I'm talking in 2025, not diagnosed usually until a clinically word. By the time it is moderately advanced, then people come to us to diagnose. And up to 60 to 85% of the people with COPD are undiagnosed. That is the worst part. And if you see global epidemiology of COPD, it has been worked out in 2009, about 390, around 400 million globally they are suffering in the percentage of around 10%. Prevalence would increase by 23% from 2020 to 2050 and approaching around 600 million. So you see that it is going to progress. Currently we have around 400, now it will go to 600. Large of people die with globally about 3 million deaths annually is reported from COPD. And it is expected that in next 40 years, that is by 2060, over 5.4 million deaths occur annually. So disease is likely to increase its morbidity and mortality. And prevalence in India, if you say it varies, various studies, I'll not quote every, but it ranges from 2 to 22% in men and 1.2 to 19% in women. That is for most of these studies. And lastly, the Salvi et al. has compiled all the data and say it is estimated around 55 million people. Around more than 5 crores people have COPD, and it is the second leading cause of death in India in 2017. And then death is concerned globally, as I said, around 3 million deaths currently. In India, around 0.84 million. More than 8 lakh people are dying with COPD. If you compare with tuberculosis, hardly about 3 lakh people. Ideally, those people also should not die, but 3 lakh people are dying. But as compared to tuberculosis, COPD death is much more common. What I'm trying to say in Indian data says that around more than 8 lakh people are dying. Now, the state-wise data also has been compiled lately, and luckily, I say that Uttar Pradesh, Maharashtra, West Bengal, these are three, Bihar, Rajasthan, these are 4 or 5 states, major states, where large number of COPD burden is there. Even mortality-wise, Uttar Pradesh is at top, and then Rajasthan, Maharashtra, and Bihar, those 4 states, mortality-wise also is on top. So what you have understood by this time, there's an enormous burden in terms of morbidity and mortality globally as well as in India. Why COPD occurs? There are many risk factors, and major risk factor what was thought when I was a student was tobacco smoking. Then even passive smoking is also responsible. Exposure to biomass fuel is another thing which has come up lately, because biomass fuel is a thing which is used in developing countries, not used in developed. So it came quite late. And then occupational exposure could be one. Sometimes alpha-1 antitrypsin deficiency, and there are many outdoor air pollutions, tuberculosis, poorly treated asthma, many poor nourishment, repeated lower respiratory tract. These are things have been implicated. Age, male gender, and socioeconomic status. They all have been implicated as you see, smoking is a major issue in COPD. You see in India, various type of, not one habit, in Western countries it is cigarette, but in our country there is a large number of smoking habits are seen. 1 billion current smokers, and what Dr. Kapil has touched, we did a lot of work on a bidi smoking, and we say bidi is much more dangerous as compared to cigarette, may it be COPD, may it be other disease. And this is the biomass fuel. Apart from smoking, biomass fuel is another very important risk factor for India and globally even. And you know, these are the examples of wood burning, cow dung cake, and so many things, coal, kerosene, they're all examples. And even not more, in Indian houses, these coils, these agarbattis, they have been lately implicated as one could be the risk factor for indoor air pollution and ultimately causing COPD. Mosquito liquid eaters have been one in some studies has been. We wrote an editorial, is a chronic obstructive pulmonary disease in a non-smoker. Initially, when we came to know, it was mainly smoker. We used to say in 80s and 90s, 90% of the COPD is because of the smoking. But now we say that not more than, this is not 25 to 45, even up to 50% burden of COPD, they are non-smoking. And the risk factor I have already alluded, biomass fuel and all those things. And the outdoor air pollution also can be responsible for COPD. Pulmonary treated pulmonary tuberculosis can also can cause COPD. Long-standing asthma may ultimately lead to COPD. And now it has been worked out that it is not simply a COPD. The various type of, various type of classification, like when it is genetically determined, we say COPD-G. Ideally, one should write on a prescription, and COPD due to abnormal lung development, D. And in environmental COPD, like cigarette smoking, we call it as C. Biomass fuel and pollution exposure, another group has been COPD-P. And if it is because of infection, COPD-I. And if it is because of asthma, lung COPD-A. And many of the patients, the COPD is unknown. And another new category has been added very recently, COPD-M, where multiple factors operate in COPD. That is what is the how it is diagnosed. I'll spend about 2-3 minutes. It's very simple to diagnose COPD. Of course, there would be symptoms like shortness of breath, chronic cough, sputum. These are the three basic symptoms. And then there would be history of exposure to the risk factors. Usually people don't seek history of these things, but it is very important that risk factors must be elicited. What are the risk factors? Because ultimately it works when you treat. And then if you suspect from symptoms and from exposure history, then spirometry is one. Dr. Umesh Kapil, which is not available in the very lower level and PSCs and other things. But spirometry that it actually establishes the diagnosis. Initial studies were done based on symptom, but now all these studies were done, they are based on spirometry. And such type of patients, in our MBBS classes, we always say the AP diameter is full-fledged emphysema. AP diameter is increased. And such type of signs are known that there is an indrawing during the inspiration. This is known as the sign. And then such type of X-rays, overinflated chest, where diaphragm goes down and lung looks large. That is overinflated chest. Even CT, we get in many CT scan. CT scan can further classify them into centrilobular emphysema, panlobular emphysema, and paraseptal emphysema. This is how but if the diagnosis is concerned, it's only good history of symptoms, history of exposure, and spirometry. They are sufficient to diagnose very easily. As you know, latest guideline says that if in spirometry, if ratio, one thing we always ask our PG student, what is the ratio? If ratio is less than 0.7, means 70%, ratio of FE1, forced expiratory volume 1, and FVC, and then measure post-bronchodilator. Give some inhaled bronchodilator and measure. If post-bronchodilator is definitely less than 0.7, then diagnosis of COPD is concerned. And if post-bronchodilator is more than 0.7, you have to follow such type of patients. And these are the normal spirometry, and these are the spirometry for the COPD patient, where you see that the ratio of F1 here in this patient is around 24%. Very severe COPD is there. Another condition where we sometimes confuse with COPD is asthma. If you see that asthma is a variable wheeze, COPD I said persistent and progressive. And usually asthma starts from childhood. COPD starts at the age of 40-45 years. Course is variable in asthma. It is progressive in COPD. And smoking, asthma sometimes may be there, but in COPD usually there. And response to bronchodilator is good in asthma, poor in COPD. And response to steroid is very good in asthma, and it may be poor in. That is how we essentially, and this is one of the examples. So in one of the case, I'll just say that 61-year-old lady who was chronic smoker, 15 BD for 35 years, and took ATT. I don't know why somebody prescribed ATT without any response, and then see, and lung is very large, enlarged lung, clearly saying, but then she developed hemoptysis, and we always say that somebody developed hemoptysis, and ultimately she developed You see the CT scan was done, she developed mass here. So it was not only simply a COPD, she also developed the bronchoscopy was done, and that has shown because of the mass and so COPD and lung cancer both were. Because each person who is a smoker, ultimately, many of them, they go to develop. The another differential diagnosis we say is interstitial lung disease, where breathlessness is progressive. It is of shorter duration, and clubbing is usually present, and bilateral basal crepes. And this is how CT picture is very typical of ILDs. That's why this is another differential diagnosis of idiopathy. So this is about diagnosis and differential diagnosis. Let me go to the management. How COPD is managed today? There are many guidelines, but very popular guideline is a GOLD guideline, Global Obstructive Lung Disease, or GOLD. Every year it is revised. 25 guideline has already come, and I'll share. And when you, what would be the essential components of the COPD management? You have to assess and monitor. First, you have to assess the disease. Then next point is reduce the risk factor. Third is manage exacerbation. So these are the points under which some of the points we'll discuss. An assessment of the initial assessment, what is the current level of patient symptom, what is the severity of the spirometric abnormalities, what is the frequency of exacerbation, and if there is any presence. So these are the 4 parameters we usually assess in every patient. Symptoms, spirometry abnormality, exacerbation number, frequency, and presence of comorbidity. And this is what modified MRC scale. I'll not go, you can read. We know how symptomatic is a person. We see the CAT score. And then spirometric, if there is a COPD means less than 0.7, then depend on the level of FEV1 is starting from, it is more than 80%. This is gold 1, mild, 50 to 80, moderate, 30 to 50, severe, and less than 30 is very, how we divide as a mild, moderate, severe. But now, initially when this table was made, ABCD, and where depending upon the severity of exacerbation and depending upon the symptoms, these things were ABCD, but now currently in 23, ABCD pattern was changed to A, B, and E. ABE means symptoms are less and the exacerbations were less. B means symptoms were more and exacerbations were less. But in E, B and D, A, B, C and D has been combined in E, and that shows more exacerbation, more than 2 moderate exacerbation, or more than 1 leading to hospitalization. And then symptom score may be less. So now it is not the spirometry by which we treat. It is we treat by what is the level of symptoms in the patient, and then what is the number of exacerbation in previous year. Based on these two, that is why this classification was lately changed, and this is still holding true in 25 also, so that we write it. So as I said, you have to assess everything, especially the comorbidities, and what is the aim of treatment, goal of treatment, relieve symptoms, improve exercise tolerance, improve health status, and prevent the disease progression, if you can do it, prevent and treat exacerbation, and then reduce mortality. Ultimately, our aim is to make patient comfortable, to improve quality of life, and if we can prevent death, that should be there. So first thing is the risk factor. I have seen that many people are still smoking, bidi smoking, they are using biomass food, so that their It has been worked up that smoking cessation is a very good tool for controlling the COPD. And clinicians should advise, and if it is biomass fuel, same thing. Treatment, there are a large list of broncho. Mainly treatment is bronchodilator. Large list of bronchodilators. I'll not go into great detail, but what I've been that bronchodilators are usually preferred. Bronchodilators are available in oral form, in injectable form, and in inhaled form. Choice goes to the inhaled because you have to use for a long time. So inhalers are the choice for bronchodilators. We have short-acting bronchodilator like salbutamol, terbutaline. We have long-acting, but long-acting we call LABA, SABA and LABA. And then we have antimuscarinics, short-acting, long-acting. So large number of bronchodilators drugs are now available. And some of the anti-inflammatory drugs, as I said, this is inflammatory disease. They are also used in COPD, although they are much more used in asthma, like inhaled corticosteroids. Oral steroids sometimes are required. Phosphodiesterase inhibitors like rofimulast, antibiotics could act, and mucoregulators and antioxidants. Then even biological has come up lately as an anti-inflammatory drugs have been used. Other anti-inflammatory drugs people have tried, statins, other things, but they have hardly any role to play in COPD. So key issues in the drug when treatment is given in an inhaled route, the importance of education and training about the inhaler device is very, very important. What we have seen in India, whatever we prescribe inhaled devices, hardly 20 to 25% they are taking correctly. So I always say, and the choice of inhaler device has to be individually tailored and will depend on the access, cost, prescriber, and most importantly, patient ability and preference. Everything is taken together. I always say this is a cafeteria mode. What you show your patients, these are the type of inhalers we have, where you are comfortable, what you would like to show. So it is a combined decision of doctors and patients. And inhaler technique and adherence, they are a very important issue. And these are the few of the examples of various inhaler devices like DPI, dry powder inhaler, single dose, multiple dose, MDIs, single DPIs, multi-dose MDI, and meter dose inhalers. So all those inhalers are, good point is available in India. And so with this basic, that bronchodilators are used, anti-inflammatory, and some patients are used. Main choice is inhaled route, and what drugs used. If you see group A and B, you have, if it is group A, it is a single bronchodilator, usually LABA or LAMA. If you have more symptom, you can combine these two. LABA means and LAMA, antimuscarinic, and then group E, you have again used combined, and in some of the patients who blood eosinophil is more than 300, there you can combine LABA, LAMA, and inhaled corticosteroid. Inhaled, not oral. This is a management of stable COPD. So essentially, I said, majority of the patients of the COPD, they used bronchodilators, maybe one, maybe two, and in some of the patients, you may use inhaled steroids, especially when blood eosinophil count is more than 6. That is how we decide about our patients. And of course, another decision is how much exacerbation patient has. If patient has exacerbating a large, then probably lava lamana acid. And another hope, if you are using multiple drugs in inhaler, choice is single inhaler therapy. Suppose one patient takes one inhaler, two inhaler, you have to train them. But nowadays, all the drugs, whether you are using one, whether you are using two, whether you are using three, all the inhaled drugs are taken through a single inhaler. In one inhaler, compliance is much better. And patient compliance is very good in single. That is the choice today. And when you say follow-up patient, still patient has dyspnea, you may change your bronchodilators. And suppose patient is still having exacerbation, then I said that during exacerbation, you have to use 3 drugs, LABA, LAMA, and inhaled steroids. And in some of the patients where you believe that they are not working, another anti-inflammatory drugs like rofimilast, especially FEV1 is less than 50%, and there's evidence of chronic bronchitis in the history. In some of the patients, azithromycin is used, especially in the former smoker, and even the biologicals have. Although biologicals are used in asthma, but in latest guideline in 25, one of the biologicals have been advised, that is duplicate, if they are not improving. That is how we go, and this is how we go adding inhaled steroids. Inhaled steroids means if there is a history of hospitalization for exacerbation of COPD, more than 2 moderate exacerbation, and there's a blood eosinophilia is more than 300, I have already eroded, and history of concomitant asthma. Suppose you have, then probably sometimes you are in doubt whether it's asthma, or sometimes both are exist together. Then in those situations, probably inhaled steroids are very important, and it favors use even if the blood eosinophil count is less than 300 and one moderate. But steroids should not be used if the repeated pneumonia events are there, blood eosinophil is less than 100 per cells, and history of myocardial infarction. Those situations you usually avoid inhalers. And there are many more drugs people are using in COPD. Let us examine, like alpha-1 antitrypsin therapy. Wherever there is a deficiency, which is very rare, then you can use it. Antitussives are usually not used in what I see people cough, so they use antitussives, cough suppressant. It should not be used. Vasodilators are usually do not improve outcome. And very severe low dose, long acting oral and parenteral opioids may be considered for treating dyspnea in a very severe distressing condition. And pulmonary hypertension, many of the COPD patients, they have pulmonary hypertension, but drug approved for primary pulmonary hypertension are not recommended for patients with pulmonary hypertension secondary to COPD. What I'm trying to say, usually pulmonary hypertension, if you treat the disease effectively, probably this will also improve. So this is about the pharmacological treatment. Now let me, another 5 minutes I'll spend non-pharmacological. There are many non-pharmacological treatments which are being used. One is pulmonary rehabilitation. This is coming up very fast. Long-term, sometimes oxygen is used wherever it is required. Smoking cessation is very important. Vaccination is also very important. And sometimes we do surgery in patients, a very advanced COPD patients. And you know, this is a patient group A, B, and E. Smoking cessation is very important. Pulmonary rehabilitation is for B and E group. That is how, and vaccination is given in every patient of COPD. And of course, smoking cessation is very important. And first part of smoking At least you ask. Many of the doctors I have seen, they never ask about this. So please ask, advise, assess, assist, and arrange so that he may be able to. This is a pulmonary rehabilitation, examples of pulmonary rehabilitation, and it has been worked, beautifully worked. There is evidence A that pulmonary rehabilitation leads to reduction in symptoms of anxiety, and many of the A's are there. Rehabilitation indicated in all patients with relevant symptoms and are risk for exacerbation. So pulmonary rehabilitation has come up one of the most important way to treat COPD. Education and self-management is also very important. Integrated care program is also, physical activity is also advised to all patients. Oxygen is advised in patients who are chronic hypoxemia, and especially if you do arterial blood gas, PO2 is less than with right-sided heart failure, then you may advise long-term oxygen therapy. And this is usually given for 15 hours. This is an example. I was in Japan. I saw an 89% is on long-term oxygen therapy. Now newer methods of using the long-term oxygen therapy has come. And in some of the patients, other ventilatory support like non-invasive pulmonary ventilation is used. Surgery, especially in the severe emphysema. Bullectomy is one bulla big bulla you can do. Lung volume reduction surgery. Now it is also now it started with and now we call it as non-surgical lung volume reduction. Without surgery, we can do it, and in some of the patients you may resort to lung transplantation. That is what is the role of surgery. These are the valves which are through bronchoscope. These valves are used, coils, to reduce the lung volume. And intervention, in COPD, usually you find bullectomy can be done, endobronchial valve you can replace, lung volume reduction surgeries, and these are the usual things which are rarely done, but it is, yes, available in some of the centers like lung volume reduction surgery, bullectomy, transplantation, especially if person is very severe, where PCO2 is more than 50, there's evidence of pulmonary hypertension, FEV1 is less than 20%, and DLCO is less than 20%. So their situation, you may think of using lung transplantation. Bronchoscopic interventions are also known. I have just shared with you, and I'll take another 1 or 2 minutes. Find as an event characterized by increased dyspnea and our cough and sputum that worsens in less than 14 days, which may be accompanied by tachypnea or tachycardia, and is often associated with increased local and systemic inflammation caused by infection, pollution, or other insult to the airway. That is actual definition. And you can assess the exacerbation, and there are various type of mild, moderate to severe. I will not go to details. Time will not permit me. And then there are usually what are the basic of exacerbation. Short-acting beta-2 agonists, very common to use. Short-acting anticholinergic drugs are also recommended. Sometimes they are combined. Systemic steroids is indicated in acute exacerbation. And it has been worked out that 5 to 7 days of steroids will improve the recovery and decrease the hospitalization. Antibiotics, if it is infection, then one can use it. Methylxanthines are usually not recommended due to increased side effects. And in acute exacerbation, one of the very common thing has come, non-invasive mechanical ventilations. They have been used in and there's evidence A, there's a good evidence that it helps. So what I'm trying to say that I'll skip some of the slides. At least one of the following, some of the patients, especially if they may need hospitalization, they may need intensive care unit, and there's a definite, if somebody is more interested, you can go on to the gold guideline. Everything is very clearly dictated in gold guideline. And I have come to end of my presentation, and certain take-home messages, what I usually give. You have understood by now that COPD is a very common disease, more common than tuberculosis. TB, if I compare, hardly about 26 lakhs in India today. COPD, we have 5 crores, more than 5. So it's a very common disease. And it is a major cause of chronic morbidity and mortality, you have seen. It is a progressive disease, largely preventable, but marginally treatable. But it can be treated. You can make life comfortable if you diagnose. Spirometry is done to confirm the diagnosis. Sometimes additional investigations are also done, that CT scan, ABCs, and other things can be done. Assessment of COPD require assessment of symptoms, degree of airflow limitation, risk of exacerbation, but the treatment will depend upon only on this, based on how much person is asymptomatic and how much is the number of exacerbation. That is why new classification has come. And then combined assessment is very essential. I have shown you that table. To treat COPD exacerbation is very, very important, because every exacerbation leads to loss of lung function. So you have to detect exacerbation early and treat them effectively. And one of the smoking cessation is a single most effective measure to prevent onset and progression. So with these few words, I would like to end but before I say thank you, I have very fond of putting YouTube lectures, especially if PGs are attending. I have YouTube lecture on history, physical examination, auscultation, X-ray reading, we book on X-ray, and then we have many books on tuberculosis and other issues also. So I would like to end my lecture. I always say that anyone who keeps learning stays young. So especially if I'm talking to the PG students and young faculty, if you want to remain young, please keep on learning. Medical science is a fast changing science. Unless you learn, you will not be able to cope up these. I know that when I was talked first time about COPD in 1970s, it was very different. And now what I have talked in 2025, there's a lot of changes has happened in COPD. With these few words, I once again thank you. Thank you all for patient listening. Thank you, the National Academy of Medical Sciences, and Dr. Kapil and Dr. Jugender for really inviting me. Thank you very much. If you have any question, I'd love to answer those questions, provided I can.
Sir, thank you. Thank you for the wonderful presentation. You very rightly said that in case of COPD, there are more options to prevent. They are like, if we can emphasize on prevention, the chances are more, and definitely treatment options are less than other diseases. So today only, once you were updating all of us, we got to know about the surgical options of treatment for COPD. So there are several questions. I would like to request all the participants to kindly type the questions in the chat box so that we can discuss all the questions. Sir, there are some questions that I have taken from YouTube, our YouTube live, which is going on. So Dr. Rahul there, he asked, sir, can increased AQI or pollution be the cause of COPD?
Yes, definitely. As I said, that the outdoor as well as indoor air pollution, they are very important cause. As you see in India, only the COPD is smoker COPD is around 50%. So rest of the 50%, more and more other things. So and out of them, I think outdoor as well as indoor air pollution, they are the very important. As you see, biomass fuel and other things, they are important, and it has already come into the etiological fact.
Sir, right. Sir, I would like to add on this question. Like, since we are residing in Delhi, so like, is there any role of air purifiers keeping at home since we like spend maximum time indoor? So,
Well, although studies are very limited, but yes,
sir,
if you want to purify your air, I mean, very small room, that you can do it. But how much benefit is it going to give? It is very. But only one. What we advise, if patient is of COPD, already existing COPD, then during the time of worst pollution time, they should not go outside. They do not do exercise outside. That is how we can little prevent about the pollution.
right, sir. Right, sir. Thank you, sir. So, next question is from Dr. Neha. Thank you, sir, for the important insights. Her question is, in persons with genetic causes of COPD, is there any provision of disability certification or any job benefits?
And you know, genetic causes are very rare in COPD. As I say, alpha 1 antitrypsin deficiency. Right. And there are a few more genes have been worked up, but that is very rare. I am not aware of any benefit given to. I think Dr. Kapil can shed more light.
Disability is a disability, so
Yeah.
nothing to do with genetic cause or non-genetic causes. Okay, disability is a disability, and it has to go to the physical medicine rehabilitation department or local CMO, and they assess this disability and give you the certificate. So nothing to do with genetic and non-genetic causes. Thank you, sir.
Thank you, sir. Sir, next question is from Dr. Ankit. Sir, what is the extent of benefit from inhalational corticosteroids in COPD? And what is the maximum recommended duration for ICS?
You know, once, that's, as I said, the COPD is main treatment is bronchodilatation. But in COPD, where blood eosinophil count is more than 300, that is one landmark, or even between 150 to 300. And second point is he has more exacerbations, means 2 exacerbations per year or 1 exacerbation with hospitalization. So these are the cases of COPD where we give, apart from bronchodilator, we give inhaled steroids also. And usually the route is inhaled, not the oral. And once we start this inhale, so then it will be a triple drug therapy. LAMA plus ICS. And we usually once we categorize patient into this group, probably the duration is very long and probably it is a lifelong. Unless he develops pneumonia or some complications, then we think otherwise. And one more thing I always suggest that now the options are available. Initially, we used to use 2 inhalers for these three drugs. Now, in a single inhaler, all the 3 drugs are available. And newer forms of steroids, newer forms of LABA and LAMA has come. That has made the life much easier. Even a single dose inhaler, usually we be prescribed twice a day. But now the single dose inhalers have come where you have to take a once. So there are a lot of improvement has occurred in therapy in a recent year. But once anybody is there, if you find ultimately the exacerbations are not happening for 2 3 years, yes, then you can reduce the steroids. But usually, in my own practice, what I have experienced, once I use this, probably you have to use for a lifelong, and your treatment is for lifelong.
Right, sir. Thank you, sir. Sir, in continuation with the same question, like that, I would like to ask. I actually served at PHC and CHC before starting my PG. So, like many elderly people who were smokers, chronic smokers, and they used to present to us, and they would ask us, "कि sir, वो दो injection लगा दो, कौन सा? Sir, Derifylin and कोर्टिसोन. सो आप 2 इंजेक्शन मुझे लगा दो, मैं ठीक हो जाऊंगा, मेरा कुछ टाइम निकल जाएगा." So that was the like common question asked by the elderly people, and maybe the practice was started by some uh, local practitioners, maybe or some quacks, maybe. So like, what an MO should do in such cases where the patient, they insist on getting some kind of injections, and they hardly go for inhalers mainly. So,
I totally agree with you that in village setup and where people are not very educated, even the inhalers may not be available in those places. There people, these two drugs, injectable, say aminophyllin and deriphyllin, and plus injectable steroids, since they are very effective, no doubt they are very, because those are the drugs which you are using in inhaler. But only problem using them injectable is it will create lot of side effects. So we have to convince our patients that and now the inhalers are available even at the remote places, even in the government PSCs, and this at least one or two common inhalers, they have been available. But this practice should be discouraged. Usually, this practice should not be, because of that they will have a lot of adverse drug reaction.
right, sir. Sir, there is another question which is asked, like in the similar area: how to select type of inhaled steroids in COPD?
Type of inhaled, there's a hardly any selection. There are many types of, like fluticasone is there, and there are newer steroids have come. But depending upon the availability, the choice goes for the, if you can use it for a single dose. But that type of, very recently they have been introduced in the market. But usually most of the inhalers having steroids, they are used twice a day. But twice a day is also okay.
Right, sir. Sir, Dr. Hira Lal Murmu, he asked about overlap syndrome is used sometimes. Can you please have a point on this?
I had one case because of the time. At the overlap syndrome is actually when COPD is also combined with obstructive sleep apnea. This is known as an overlap syndrome. What happens? Many patients of COPD, they are obese, they are snorer, and if you perform polysomnography, you'll find that apnea hypopnea index is more than 5. Then you call it as he is also suffering from OSA also, obstructive sleep apnea also, and that is known as overlap. And there, apart from the COPD management, probably you have to also think of giving him CPAP, continuous CPAP pressure, and so that he becomes comfortable. Another overlap syndrome, if the CO2 is also high, then even non-invasive ventilator therapy is also used in this BiPAP, what you call it.
Sir, what are the 5 interventions you will recommend for prevention of COPD in urban area and in rural area?
Sir, in urban area, the first thing I always say that prevention of smoking is very, very. And I always tell my patient, even if you have smoked and if he has not developed, so stopping smoking, first I say that never start it. Suppose you have already started it, then stop it. Whenever you will stop, you will get the benefit. So that is the first thing. And in the rural area, the one, yeah, huh? So I'm sorry, there are some lapse in the, and in the rural area, I believe the use of biomass fuel is very rampant. Still, it is rampant. Though no, I know that there's a Ujjwala program, there's a so that definitely has there are studies after studies. We did a lot of work on use of biomass fuel and COPD and tuberculosis. And so that is the another very major issue where probably all the biomass fuel should be replaced with a clean fuel. And I say best clean fuel is electricity, and then next then is LPG. So I mean these two things and second thing, third thing, whenever you develop such type of symptom, please visit your hospital. So to doctors, so that he can say that whether you have early COPD or not. Because if you detect early COPD, then chances of developing going into the severe COPD, emphysema, that is known as is sort of a secondary prevention of the COPD. Because we see large number of deaths with the COPD. So these are 2-3 points coming to my mind. And then of course the pollution is one thing, outdoor pollution, anybody individual hardly can do it. But as I said, if you have a COPD, if you avoid those polluted areas where there's especially now we have got warnings, everything that pollution level in Delhi especially is one of the most polluted city of the world. So those are the issues where you have to, but only thing preventable, what to my understanding, smoking is a very important. Use of biomass fuel is also very important, and early detection of COPD. And early detection may not be by symptoms, it may be by spirometry. That is how I see, especially in those who are 45, who have been exposed to these things, they must be screened.
सर स्पायरोमीटर तो मिलता नहीं है, कहाँ जाए बेचारा मरीज?
सर
पीएचसी में नहीं है, सीएससी में नहीं है, डिस्ट्रिक्ट हॉस्पिटल में नहीं है, अगर है तो उनको समझ में नहीं आता है कि इसका स्पायरोमेट्री कराना चाहिए.
I totally agree with you, Dr. Kapil. Spirometry, though it's very simple, but its performance is very, very difficult. It is an effort dependent. But even if you don't have spirometry, if you know how to take a good history, if you know how to do physical examination, that would be sufficient to diagnose COPD. Confirmation, it must come from COPD, but confirmation every time is not required, especially the equipments are not available. In the history is very, as I said, asthma and COPD, these are two, and third is ILD. These are the three common conditions where people have a breathlessness. But if you are clinically, you have been viable person, if somebody can train that, he can very clearly differentiate between COPD, asthma, and ILD.
Any role of monoclonal antibodies, sir?
Monoclonal antibodies, I said that biologicals have come into the treatment of asthma in a large way. But in COPD, in one of the group where eosinophil is very high in COPD, rather initially we used to say asthma, COPD overlap. Now that term has been abolished. Now it is asthma and COPD may be combined. In those situations, some of the biologicals in recent guidelines, they have advised as a monoclonal.
Right, sir. Thank you, sir. Thank you for the wonderful discussion. It was really enriching for all of us. So Is there any other question? You can still put in the chat box, or we can proceed towards the. Okay, so now I would like to request Professor Umesh Kapil sir for the word of thanks.
Oh, thank you, Jaswant, for. It's a proud privilege to thank Professor Rajinder Prasad, sir, who is our council member as well as emeritus professor, and his work is known not only in the country but internationally. My thanks to all the participants who have. I am sure that they must have learned at least few tips how to handle the COPD, how to diagnose it, how to differentiate between asthma and COPD, what should be the management, and then they must have also learned that what are the causes and how to prevent them. It's a slightly a difficult area if you ask me. You go to the rural area where over 60-70% of population reside, there's only one room in which the mother cooks also. She uses the cow dung and the biomass fuel. It goes into the air. She has to inhale it. There's not much choice with her. Anyway, that's a way of life. But yes, the government of India has initiated large number of schemes like Ujjwala scheme. Even in some of the villages in Haryana, we have piped gas supply. PNG is there. So there are a lot of efforts are being going on, and we must appreciate the government of India. And since the development in our country is in transitional stage, we are going to make a lot of progress. My most sincere thanks to Mr. Ravi and Dr. Jaswant. Jaswant is an assistant professor in AIMS, and he has been helping us and facilitating the Navigate program. Thank you very much, all of you, and please visit our NAM's website for. If you have missed out a point, you can just write to us on our email, or you can write to Dr. Rajinder Prasad sir on his email and get the clarifications. There are many questions must be there, but please do write us. Thank you very much again. Most grateful to all of you. Namaskar.
Thank you, sir. Thank you very much. And if I can tell my email address, if anybody had any query, my email address is a very simple, rprasad@gmail.com. I think so. Anybody can write to me if any question. I once again in the end, I must thank Dr. Kapil and Dr. Yogender, and especially all the persons of National Academy for inviting me and allowing me to share some of our ideas about the chronic obstructive pulmonary disease. Once again, thank you very much, Kapil Saab and Yogender.
Thank you, sir.
It was always very heartening, Dr. Kapil and Yogender, to listen to you. Last time, always I relish it.